is the Kildare West Wicklow a pilot programme, or is it available elsewhere in the country?
Thanks for the question. I'm not sure that it's a pilot program in the sense that it implies that there's some kind of plan. It's just kind of developed organically, actually. So it's a local program, but it's certainly, we have received a lot of support from senior HSE managers to fund and explore different ways of approaching the structural difficulties that we were talking about earlier on. So I certainly would feel that there's a lot of goodwill within the HSE in seeking different models of care that might be more effective and both more quality effective and cost effective. So I suppose in effect it has served as a pilot project, and certainly we hope to use the information that we've gathered through our research to promote this as one model of care which we would like to offer to other services as a way of stimulating other services to look at ways that they can improve their service. We're not at all suggesting that it's the only way to provide good care, absolutely not, and we feel that there's room for a whole lot of different types of models, and a lot of interplay can happen, useful interactions, I suppose, around different models, but this is one model that we have researched, that we can offer, and that we feel we can stand over in terms of improving on what is on the level of care that most people receive.
It does sound like an amazing program.
Gentleman here, and then I come to you. Yeah.
I'm rather hesitant, really, in speaking, because it's extremely personal, and I don't want to delay anybody, but I've presented myself to A&E about 30 times, and in Tala, and I have waited 16 hours in some cases, and I just happened to pick up the interview there with your good self and Owen Butler, and I just read it, and I said, at the time when I was reading it, I was staying in a hotel because I couldn't stay at home because I was suicidal. At the moment, just incidentally, I'm staying in a youth hostel because I'm afraid to be on my own. Now, the chances are I'm going to end up in A&E tonight because I'm very unwell at the moment. But I just want to let people know this is my experience. I've had about 30 admissions to A&E, 16 hours of waiting. And when I do eventually get to speak to a psychiatrist, I had to plead one night. I threatened to, I'm not sure threatened is the correct word, to ring RTE or the Irish Times to get me into a hospital. Eventually they gave in. Now, I'm not saying they're incorrect or they're working in a system that is totally flawed for me personally. So I got into this system. I spent a weekend in the psychiatric unit in Tala, which was totally and utterly inappropriate for me, because there were people there, unfortunately, who were extremely unwell and violently unwell, where you would be liable to be attacked verbally or physically. So here I am tonight. I don't see myself not going to A&E tonight. So I just need to share that here in this room and to see it in its raw sense, that my life, and has been for 25 years, high risk. And I have been sent away, and I've told the psychiatrists down in Tala, you're sending me away, and there is a high risk that I am going to commit suicide tonight. And they say to me, well, my judgment is that you won't. So that's really the gist of my story. And I just don't feel much hope at this moment in time for me as an individual. Now, other people may find the system works for them, but for me, it's not working. And my life is at risk as we speak.
Thank you very much indeed. And clearly, we all hope very much that is not so. 16 hours in A&E. If you weren't in a crisis, is impossible. I mean, well, A&E for everybody is impossible, but I mean, 16 hours is unimaginable, no more than you filling in the day in a day room looking at the walls. I mean, I don't know how people go put up with it. Sorry, this lady here.
I worked in London over 20 years ago as a senior casualty nurse, and I remember, you know, as your stories are saying, and to this day I don't even think things have changed. And I wonder, and I do agree with your project is extremely really good, but I wonder, is there something we can do at the moment while bridging in a casualty? Is there somebody we can provide? Because it's always, you know, the nurses, maybe the nurses aren't trained in that area. I don't know. I actually went into, as a counsellor, I am now myself at the moment, but I wonder, is there something that can be provided for people that are waiting in casualties? You know, is there something that can be set up? I don't know, as a bridging, until projects like these are coming about, you know, someone to listen and to hear you and talk to you and time with you.
I think I spoke to a number of medical students and psychiatric nurses who are on placement in A&E recently, and one of them actually came out with the phrase that we're told to treat them and street them, which I thought was very sad. And that's today, that's not 20 years ago. And I think that the problem is that many people don't have training around mental health, and especially around self-harm and suicide. And I think in this day and age, that's an absolute disgrace. As I said, for me, all I ever wanted was to talk to someone who would treat me with respect, and just like anyone else wants when they go into the hospital. And I do think there is a little bit of training that's needed. I think that everyone should have training around mental health. Everyone should do assist training, whether you're a mental health professional or not. And I think that if everyone did do assist training, which is suicide first aid, I think that we'd have a very different community and a very different way of helping people who are suicidal.
I know that the National Office for Suicide Prevention...
Can you speak up a tiny little bit, because it won't hear you at the back of the room?
I know that the National Office for Suicide Prevention are currently putting nurses in A&Es around the country. I don't know if they're in all of them, but they've started this process recently of putting nurses in A&E units in some hospitals in the country. So therefore, if a patient comes in who is suicidal, that patient will be seen immediately by a suicide nurse. So that's a first step. I think it's a good move. The other thing is, I get the feeling that, again, it comes back to general practice. I think GPs need someone that they can call, that they know will see that person immediately if it's an emergency, or at least can assess them to know that, you know, whether, okay, this is an emergency or it's not. We need a psychiatrist or a mental health professional, like a nurse who's specialist in the area, to do that. I get the sense there's a frustration amongst GPs that they do a wonderful job in looking after mental health difficulties in general, but when there's a crisis, they're stuck as to who to go to. So I know I spoke to a couple who said to me, if I could just pick up the phone and ring one person who will see that patient, who I know will mind that patient, and that patient will be sorted, rather than having to go check up whether the person's in the right catchment area, whether they'll be seen in that area, then go to A&E, then wait for hours. So I think one point of contact might be an idea as well.
Actually, excuse me, I chaired a thing some years ago for awards within the public service selection, and there was another model. Now, I'm not sure for certain if it was in Cavan, but what had really been constructed and worked well was the relationship between I don't know whether it was the hospital or the psychiatrist and the GP, where they knew there was mutual respect and understanding of people's time and status and all of that kind of thing, and that it also had done, as you had said, had a much more immediate intervention rather than this going to A&E. Gentleman down the back, there are two down there that want to speak, I think. Yes, the man in the grey first, yeah, and then you.
Thank you. My name is Michael Sherlock. I work as a mental health nurse. I'm in my 34th year in working in mental health. And, you know... Could
you hold that a little bit?
I can, of course, yeah. You know, I feel that I have to apologise on behalf of the psychiatric profession in terms of the delivery of care that we actually give. And it kills me to see day in, day out the suffering of people trying to get into our services and can't get access to people like myself who can help them, you know. You know, if we reflect back on St. Brendan's Hospital, which has lots of good stories and bad stories about it, we had in the 80s an A&E department with the reg on call all night. You had 4 staff nurses, you had 2 male, 2 female, and we had 4 male beds and 4 female beds. You could come in there off the street 24 hours a day, and you would be seen, and you would have somebody who would sit with you if you needed all night and listen to you, and not in an A&E department. When they decided to close it down and move on to the more the less discriminatory A&E assessment process, we as nurses fought it as much as we could to stop it, because we could see the chaos that was coming down the tracks. And unfortunately, that's where we are today. And Dr. Gibbons sounds like he's running a very good service down in Kildare, and I take my hat off to him, but that's not replicated all around the country. And that's just the point I'd like to make. Thank you.
Okay, thank you very much. I think that it became fashionable at some stage to change from institutional care, and there was this kind of catch-all phrase of care in the community. But while they closed down the institutions, they never set up the proper care in the community. It seems to me that it was a political more than anything else. Gentleman back here, then I'll come to you. Yes?
Hi, Jerry Raleigh is my name. I'm from the National Office for Suicide Prevention, and it's great to thank Mental Health Reform for inviting me along tonight. And it's really a wonderful opportunity to hear people's experiences, which in the main from tonight have been less than positive. Our task in the National Office is to oversee the implementation of the National Strategy on Suicide Prevention. It's called Reach Out, and it's a document that's coming to the end of its life this year. So at the moment we're getting into gear with the department and with the community, because our view very strongly is the response to suicide prevention has to be based in the community and have a very strong community focus. But it's important to hear people's testimonies and people's experiences to help us guide us in terms of the next phase of suicide prevention in Ireland. The task, just listening to the experiences today or this evening, it's really daunting. And one wonders where you begin. But we have to begin somewhere, and there's a lot of good work going on, and there's a lot of good intention, and there are a lot of models of service that are working. I think we're really conscious in the National Office of the 9,500 people who do present in A&Es every year, about 12,500 presentations. We're very conscious that that may only be the tip of the iceberg, and that there are many people who aren't going to A&E, right, and who may not be receiving care. We're also very conscious from the data we have, which is really important to us, that people's experiences in A&E, including very long waiting times, etc., to the point that people walk out the door without ever being seen, just isn't good enough and has to be remedied. There's a couple of small steps in the offing that I think June referred to, that we're trying to develop this year. The first is around the work that happens in A&Es, and I take the point that they're not the appropriate environment in all cases, and I think we need to get away from there. But as a first step, it is our endeavour to put trained nurses, qualified nurses at a senior enough level, who will lead both the training and the triaging of people in A&E who present with self-harm, to make sure that nobody gets lost in the system, and that people are referred appropriately along the line.
Right.
I think that's really important. Now, I think the recruitment of those people is well in hand. Some people have already arrived, thank God, because recruitment can be a terribly torturous process. But we want these people to take strong leadership roles in A&Es in terms of supporting people. The second thing, and it's been mentioned a couple of times, is about bridging the connect between primary care, particularly the GPs, and the mental health services. Because it's usually in the cracks that people get lost and fall into difficulty. And there's one programme that we've evaluated very strongly. Now, in an ideal world, you wouldn't need it, because mental health and primary care would be hand in glove. But that's not the reality. We strongly tested a programme called SCAN, a suicide crisis assessment nurse in Dublin South and in Wexford. And it had really strong evidence around it. Basically what it is, it's a nurse who's part of the mental health team, a very experienced nurse, who's available to GPs, So the GP rings the nurse and says, I have somebody in my surgery whom I'm really concerned about. Can you come out and do a full assessment? And that person has the responsibility and the clinical backup from within the mental health service to make things happen quickly. It's been proven really effective at short-circuiting admission processes, etc. And people have got access to service. Not always, they may not always need access to mental health service. It could be counselling in terms of marriage guidance or financial guidance or all of the above, but that person can make that happen.
Right.
This year we're in the process of rolling out 8 more sites across the country. I think there's 2 here in Dublin, there's 1 in Cork, there's 1 in Galway, 1 in Donegal, and 1 in Sligo, and 1 in Waterford. And we'd hope to develop that service as an option, not as the solution, but as part of the architecture along the way. There's small steps. We have a long way to go.
Right.
Thank you.
Okay, there's a lady here, there's a lady down the back, and there's a couple more here. So in that order. Excuse me.
My name's Anne Foley, and I've been a service user for over 16 years, and I've seen both sides, the institutional side and the community team, and Dr. Gibbons' team does exist in Wexford as well, thankfully. I am also on the consumer panel for mental health in the Wexford-Waterford area, and when St. Senan's closed 4 years ago, can I tell you that as patients, and that's the wrong word because we're called service users, but as patients, all the patients who attended St. Senan's were petrified of going to Waterford A&E and Waterford Psychiatric Ward because we didn't know the staff, we didn't know what way they operated, and we didn't know what way we were going, what the ward was like or anything. We hadn't seen it. But in saying that, community teams were put in place in Wexford, and I can say that we have one of the best community teams at the moment, other than yourself, in New Ross and in Wexford and Enniscorthy, and we're all interlinked. But at the moment, the team themselves have been told that they have to decide where they want to work, that the staffing shortages created by the HSC has meant that the hospital must be serviced first and that the staff will be redeployed back into a hospital service. Now these staff work, I won't say day and night, but they work daily. We don't have a 7-day service in New Ross. There is in Wexford, and it's the only one in the county. And that the staff themselves are nervous about having to go back into a hospital situation because they know they are needed in the community. So my question to the panel is, if there's cuts, and I know we lost 15 million this year, and why is it that mental health are hit the most when there is such a stigma in the country as it is? And I've faced it personally and professionally as well. You know, people just can't accept that you have a mental health illness in this country, and I'm not afraid to talk about it. I have given interviews with Shari, I've given interviews with Lara, I've given interviews for RTE, I've given interviews for radio. I am not ashamed to talk about it. I was like yourself, I was on medication for 10 years and I was like a walking zombie. But because now I have a community team, I have the benefit of talking, and I know I can pick up a phone in the morning and tell my key worker I'm in crisis, or tell my key worker I had a great night out last night. You know, so the community team does work, but why in this day and age? Like, I mean, the government are all on big salaries. Let them take a cut, for crying out loud, because it's not fair. Cutting mental health again this year is not right. So that's my question to the panel. Why is it always mental health that gets cut?
Well, can I put a proposal? And that it is that if you look at people, and it was one of the things my friend said to me about her son, and she doesn't object to a sou going to anybody else, but she was saying that for some groups of people, she talked particularly about mental disability as opposed to mental health, that they are very well organised at battening down doors and and that's what you do. I think in a democracy you just keep at it and shout and make your voice heard louder than anybody else. I'll come to you in a second, but I've promised a lady that's been waiting down there for ages. Does anybody else on the panel want to comment on that?
I think it's whoever. Unfortunately, there's no votes in mental health. There really isn't, and I think
I'm going to disagree with
Are you? Okay. That's cool. I don't think there are. I think, thankfully, thanks to work of people like Mental Health Forum, like Spun Out, all these groups, there's more groups coming together now, and I think the last couple of years we are seeing a shift in it. But we just need to keep, as Marian said, we just need to keep fighting and keep shouting and keep, because those who shout loudest in the Irish Health Service gets the most, and it's true. I mean, and until we start treating mental illness like we do physical illness, I think they both should be on a par. You see the cancer services, for example, how excellent they are now. So until we have physical illness and mental illness on a par in this country, we won't have the services that it deserves.
Okay, woman down the back, yes.
Hi, thank you. I just want to say thank you to the panellists for sharing their stories and for being so open and honest with us. You're very brave to do that. And also for everyone for giving their time into mental health reform, for organising the event. My name's Fionn Fitzpatrick. I'm a community development worker with the Gateway Mental Health Project. And something that I wanted to raise, which wasn't mentioned by the panel, is the very sad and traumatic reality for many people in the community who perhaps need care as a result of a mental health crisis, and that is the use of the Gardaí. Now, we had an issue over the Christmas where somebody was known to be in a potential mental health crisis, and we hadn't heard from them for a while. And the only option available to us as a project was to contact the local Gardaí. And it's not an acceptable or appropriate way to make contact with somebody who is in quite a significant state of distress. And I just wondered what the panel's thoughts were on the use of Gardaí, and also maybe Dr. Gibbons' view and experience in his area as well. So thank you.
Yeah, mind you, he has that terrific system whereby the key person or a member of the team will be at the end of a phone. Anyway, we'll let you respond to that.
I suppose, look, I don't think anybody would suggest that, and nor would the Gardaí indeed, that they have training in mental health or dealing with mental health crises in particular, when somebody is, I suppose, at their most vulnerable. But on the other hand, there can be circumstances where, for legal reasons, for example, if you can't get access, if somebody's, for example, inside their home but doesn't wish to answer or isn't able to answer at the door, there are some particular situations where we're very appreciative of getting the help of the Gardaí. I think the Gardaí themselves are very, obviously have their own issues in terms of how to respond given their training and their role. So they have their own anxieties, I suppose, around assisting with mental health. I think it's something that they, obviously there are particular situations where we will need their assistance, but as long as those are very clearly boundaried, clearly described, and as long as everybody involved, including the guards, know precisely what their role is, and that they do have the appropriate training so that they can handle the situation as sensitively and as carefully as possible, and obviously to try and minimise those situations, because of course it does raise all sorts of other issues for the person in distress. So
lady here, yeah, I'll come back to you. I have a couple more down here that I have to go to. This lady here, yes. Just can you hold on till we get you the microphone?
I'd just like to say that as a family member of somebody that is using the service in Selbridge, that they have really saved our lives as a family, because it's a wonderful service. And even when the person would be staying with me in Dublin, they would still ring her in our house, and we could ring them when we feel that maybe she's unwell. And I just can't believe that we have had such support from them, over the past 5 years. And I just wanted to say that's a fantastic service and really should be rolled out across more areas.
Good to hear it. Good to hear it. Take a bow.
Thank you.
There was a lady, I think that lady, this lady, and then here, yeah.
I have a quick question for Dr. Gibbon. The model, I suppose, in North Kildare, is it going to be rolled out in South Kildare, given that you've compared it with that service? I suppose it's just a personal interest as well. Yeah.
Sure. The comparison service wasn't actually, it wasn't the South Kildare. There's
Okay.
4 sectors in Kildare altogether, so it was one of the mid Kildare sectors that we were actually comparing it to. I suppose, is there a plan to roll it out? Well, not specifically, actually. No, there isn't. There's an ongoing process, which isn't just in Kildare, but I think it's a matter of trying to promote, explain, raise the profile of the particular model, not just in Kildare but in other places too, really just to continue a conversation of persuasion, really, because service providers, as the same as service users, can have all sorts of anxieties, complexes and hang-ups around change. And I think we see our role, I suppose, as trying to communicate and explain and present this model as widely as possible. So, opportunities like this and conferences and like any opportunity we can get, we will go to and we will present the model. But there isn't a formal process of rolling this model out elsewhere yet. But we're still working on the HSE and trying to persuade the HSE leaders that this is a good way to work and that it may be of interest and may be helpful to other services. So there's an ongoing discussion around it, but there isn't a plan at this point, unfortunately.
This lady here, then I come to you.
Thank you. I just want, there are 2 points I want to make. One is to do with assessment, and just, I suppose, to give people the information that a free assessment service exists through the Dean clinics in St Patrick's Mental Health Services. Any GP can refer a patient to the free assessment clinics. Now, what that means basically is that your assessment will be done for nothing. Obviously, the idea is to encourage people to use the service, but you can still have your assessment done, go away with your assessment and get your services elsewhere. Nothing to prevent anybody from doing that. So I just wanted to give people that information. The second thing I wanted to raise the point that whatever hope adults have of accessing appropriate mental health services, child and adolescent mental health services in this country haven't been mentioned tonight directly. Now, both the panel members who've experienced their own issues did say that they were young. They were one of them. I know that Marie mentioned that she was 17 when she first accessed mental health services. The numbers of young people in this country who are being admitted to inappropriate adult mental health services is, I don't know what the actual numbers are, but they are there. They're not accessing the correct services for their age bracket. The services don't exist, appropriate services don't exist for their age bracket as well. And there's also another anomaly where a child of 16 can make a decision about issues surrounding their physical health, but is not in a position to make a decision around their mental health. So parents of young children, or of children under 18, are under enormous stress to access services for their children. And I really just wanted to make the point that while we're talking about early intervention and access to services, we have to remember that children need access to services. And if we make that early intervention, when the children are under 18, chances are that they may not have to use the services as much when they're older.
Right.
Thanks.
Okay, point taken. This woman here, then there, and then to the back. Yeah.
Thank you. My name is Eileen. I'm from New Ross in County Wexford, and I'm a service user for the last 20 odd years, and also have a family member at the moment who is inpatient in Arkeen in Waterford, and she was diagnosed when she was 14, and she's also deaf, so she has very crisis. When she's in crisis, she has no access to interpreters and stuff like that. But I just want to say that there is life after mental health problems, that life goes on, and that there is life outside. And also someone was talking about TDs and knocking down doors. I think this year is in the summer of the local elections, and now is the time to lobby your TDs and get on to them and let them know that how we feel about our mental health, like, you know what I mean? And when they come knocking for your votes, to let them know how we feel and make them listen, because we have to listen to their shit the whole time. So make them listen to us. Thank you.
There was a lady, yes, this lady. Just this lady.
Hello, my name's Fiona. I just I suppose I'm a patient of the team.